Check, try and look for it.
I do only one spot for us.
It's not my data. It's the one that you talk.
My data no be small.
I sent it. She sent it to the group. To the rest.
Spaghetti or rice, that's it. No, sincerely, and I made much more than
Increase your brightness. It's clear. You think it's clear enough?
So if I use the app, I can buy
A little bit.
yes, when you start using the app, they'll give you 20 gig.
What am I just saying about this app?
Let me go.
Let us hear what now?
If you go to the airport, 15 days they are free.
That
Airport lounge, everything there is free. That's what if you keep using the app, there's a value. They're giving you stars. They're letting you walk. When you go to the airport, you have MTN lounge where you stay.
Yes, sir.
22A. MTN app.
3 people have joined the race.
On your
I used to don't depend on your what days you call it to M-Pulse and your tariff plan. Just depend on tariff of it. On mute? No.
No, you can download it yourself.
are we good to go?
Good to go, good to go.
Good afternoon.
Good afternoon.
Adeoli, please monitor that I should see that questions from them. Now, today, I will be going over what we started recently, all over again, and try to bring it to a reasonable conclusion. Right? We are discussing drugs used in the respiratory system, and based on my note here, I tend to move from one to the other. Now, most of us know the conditions we are dealing with, from asthma to COPD to rhinitis to cough. What else? Then at some point we have to discuss tuberculosis. Like, when you look at all the problems there, you are looking at either the upper respiratory tract or the lower respiratory tract. Most of the issues around the upper respiratory tract are mild. They are not serious. Cough is not usually serious. Rhinitis is not usually serious, right? So our goal is not just to define them, but we want to work on the drugs that can be used for therapy. And the other day, while we were discussing, I mentioned I didn't dwell on the pathophysiology, right? I didn't dwell on the pathophysiology of asthma or COPD, but they are so similar in that what do you see? You see cough in the patient. You find bronchospasm in the patient, right?
Yes.
You find bronchoconstriction, is not a bronchospasm. There is always wheezing. Then, usually there is an edema along the respiratory tract. So, these are the major issues that we have with asthma or COPD. So, now, it's just that it's an upper respiratory tract and then lower respiratory tract, right? Respiratory tract. So for the upper, so we're looking at things like cough, rhinitis, is it glossitis, some of those things? Maybe family, is it glossitis, right? Something like glossitis, etc. But yeah, you look at the asthma, COPD, etc. So there's a reason why we do not put tuberculosis in any of these groups, because tuberculosis is an infective, right? It's communicable. It's not like this one, like you cannot transfer asthma from yourself to me. It's not communicable. But tuberculosis is usually communicable. So it's a different thing that we have to discuss, but we have to discuss it. So while I discussed that, I mentioned that we look at, so what I want to run through is, I have like 2 or 3 notes. I want to run through them so that we can together. But with this note, I'm going to have to discuss tuberculosis here, but this doesn't really have tuberculosis. So having discussed the some of the pathophysiologies like I mentioned, you find in your notes that I sent to you. Then we said that usually with asthma, there's always an allergy, usually an allergic condition, like there is allergy involved. So we have an allergic response, right? All of us should understand that with asthma, we have what? An allergic response. So since we have an allergic response, we know what an allergy is part of your immunological, should I call it response? Immunological, also response in the body. So in allergy, we have cells from the immune system involved in everything that's happening there. So it may also mean that, so what we now tend to see with asthma is, let me just highlight it, we have what we said, bronchospasm there, also bronchoconstriction, right? We have wheezing, we have coughing, we have pulmonary edema. What else? I think majorly these are some of the things we have there. So these are usually the end product of what started as an allergy. That is the point. These are usually what the end product of what started as an allergy. So and we say that by the time you're seeing all of these, the allergic reaction had gone far, right? So when we say that we have an allergic reaction and we have probably immune reaction, so normally with allergic reactions, you could use just like what antihistamines, right? At times you can use antihistamines. What else for your allergy? What else? At times people use corticosteroids. Corticosteroids for allergies, right?
Yes, sir.
What else for allergies? Antihistamines or anti-inflammatory, right? At times some people get anti-inflammatory agents too, which will be similar to this. Sometimes some cannot be so this. But the other drugs we are going to add here are drugs like what? We have your bronchodilators, and that is where I want you to I want your bronchodilators. Majorly, that's what we are going to add. Bronchodilators. Because it is usually an immune response, so at times we have different type of what we don't call it suppressors, but we say immunomodulators. Immunomodulators. So, but they are minor drugs. These are almost all the drugs we are going to talk about with. Are we together? These are usually the drugs we will talk about when it comes to issues in the lower respiratory tract. Now, to highlight the issues or the drugs we need for things in the upper respiratory tract, this is blue. Probably I want to use. We're looking at since there is cough there, you want to look at drugs like antitussive agents. Antitussive agents, right? At times too, you might consider antihistamines here. Consider mucolytic agents. You also have expectorants here. Then you also have some sympathomimetics here. Usually, we're looking at alpha-1 agents here. Probably around to that. What we talk about here, we said beta-2 there. So mostly, your cough syrup will contain almost all of these together. You just want to understand them and not count them. Is that okay?
Yes, sir.
So, to discuss about the drugs now, have a look at what you plan to do. So, in treating asthma and COPD, you want to reduce frequency of symptoms. Frequency of symptoms, severity of symptoms, right? Yes. Frequency of how many times it happens. Severity was how difficult was the last episode or the next episode. Then you also want to prevent daytime symptoms, because there's usually for respiratory issues they will increase during the night time. So which means that the patient will not sleep, right? So if the patient will not sleep, what have we done? That's another issue. So the reason why at times some of them have antihistamines added, do you understand? Or an agent that would, the other times, okay, what I mean is that is you have some, maybe let me just put an analgesic there. You have the form of some type of analgesics there. Analgesic there. So I was going to add maybe a sleeping pill, but since I mentioned antihistamine, you need to, these are things, once you have this in your mind, you will not need to count a lot of things. You understand the condition, understand the pathophysiology, right? So the point is we are trying to treat the symptoms involved. That's what we are just trying to do. What do I mean? Because we're just trying to treat the symptoms involved. The other times you need to remember the receptors that most of the drugs will work on. It helps you to simplify everything. Do you understand? Alright. So moving on from the treatment of asthma, so I said for asthma, we have several drug classes that use bronchodilators on the board. The last time I called bronchodilators relievers, right?
Yes, sir.
We have corticosteroids there. We call this one preventers. So the point is, corticosteroids, antihistamines, sometimes may be called preventers. When you say preventers, you are trying to prevent something from starting. That is it.
Yeah.
When you call it a reliever, you are not trying to alleviate what is happening. So one is to ensure that it does not happen. The other is to ensure that what? Just to ensure that this person do not die in the process. So we have that one there. So we have drugs that are called maintenance and reliever therapy. We have sodium chromoglycate. Any of the drugs we talk about would either be a any drug for asthma, any drug we are talking about would either be a bronchodilator or an anti-inflammatory agent. Basic. Worst case, maybe behave both ways. Will either be a bronchodilator or anti-inflammatory agent. So the mechanism of action may be different, but basically it is that. So your sodium chromoglycate, your neosodium, neodochromic sodium, your leukotriene modifiers will fall here. So agents that are like this, they may not exactly be bronchodilators or dilate inflammatory. But the point is, we said what all of this whether allergic is an immune system reaction. So by giving agents that represent or that look like something from your immune system, you are modulating. Like I said, immunomodulators. What they tend to modulate the immune system as a whole. But the point is, in a way, what I'm trying to do, you want to reduce inflammation. Beyond that, we have xanthines, methylxanthines. So methylxanthines here, we call them preventers. And I mentioned that your methylxanthines, which is a drug class of component you get there, are just like your aminophylline and theophylline, right? So that is that. So having said that, I just want to go to our bronchodilators. So I just intend to move as fast as possible with each drug class, and we move on. Our bronchodilators here. Okay. So moving on to bronchodilators, and we now need to rub off everything on the board. Now, for bronchodilators, we said that one of the critical symptoms of asthma is what? Bronchoconstriction. Bronchospasm. Bronchoconstriction, bronchospasm. So, the reason why you need the bronchodilator is because you want to relieve bronchospasm or bronchoconstriction. That is basic. So, by definition, looking at the mechanism of action, that the drug now have to employ any technique to ensure it does that. So, majorly, when we look at bronchodilators, for bronchodilators, I said we look at what? Either a sympathetic agent or let me call it a muscarinic. Basically, the first two muscarinic agents. This is clear, right? And for this, we measure two Sabas and Lavas. For this, we measure two Samas and Lamas. So what we said was what? The Sama is what? The short-acting beta-2 adrenergic agonist. If you can remember that, you know the mechanism of action already. Short-acting adrenergic. Abi?
Yes, sir. Agonist.
Beta-2 agonist. So, why is it short-acting? The other day, I explained that was your sympathetic nervous system releases noradrenaline as the neurotransmitter. Why paracranial system, we use acetylcholine as the neurotransmitter. So, noradrenaline is very similar to your adrenaline. So when we look at what you get with your adrenaline, once your body releases adrenaline, the major areas that it will bind to what we call adrenergic receptors. So adrenergic receptors are alpha 1, alpha 2, sometimes you might find alpha 3, but beta 1, beta 2. These are your adrenergic receptors. We said alpha 1 basically are found on blood vessels, smooth muscles of the blood vessels, and blood vessels, majorly the smooth muscles there. Find them there. Alpha 2 has what we call more or less like a modulatory effects. Usually, I think centrally acting modulatory effects in that region. It may leave alpha 3 because it's not so common. So your beta 1 are majorly found on cardiac, majorly. I'm not sure that's the only place you find them. Your cardiac muscles. Your beta 2 on smooth muscles. Everywhere. So wherever you have smooth muscles, you will find what beta 2 receptor there. So the point is for you to understand, get the knowledge first. Physiologically, when adrenaline binds to any of these receptors, what will happen? You get it? What you need to inform when the agonist, we call when the agonist here, or we call it endogenous ligand, because I said that what the drugs were introduced in your body and we're not the ones that made the receptors. There are already receptors in our bodies that drugs you want to introduce you would take advantage of. So normally there has to be a ligand or something in your body that can bind to that receptor first. Do you understand? So if our bodies has what we call adrenergic receptors, right? For something we call them what? Adrenergic receptors. Because of what? Adrenaline. We have adrenergic receptors. So we expect adrenaline to be able to bind to all of these receptors. We'll also expect a drug that can mimic or that will look like adrenaline to bind to these receptors. So how do we now classify the agonist and agonist fast? The endogenous ligand that binds there, what does it do? Do you understand? So when you understand what the endogenous ligand that binds there, what it does, you can now say you're not giving another chemical agent to behave as an antagonist if you want to negate what the endogenous ligand does. Is that okay? So, what did he say here? So that what? When adrenaline for example, or no adrenaline, when it binds to alpha 1, it causes bronchoconstriction. I said broncho. It causes vasoconstriction. So, when adrenaline binds here, you have what? Vasoconstriction. So that is an agonist there. It's not an antagonist. Adrenaline binding to alpha 1 receptor produces vasoconstriction. I said this produces a modulatory effect essentially. It has use in hypertension and other cases. We read that. Now, when adrenaline binds to beta 1 receptors in the cardiac muscles, what we have is what? We have increase in chrono and inotropic effects. Is clear, right?
Yes.
Basically, that's not all we see. So, for smooth muscles, it causes what? Relaxation of these muscles. If you understand it, your work gets simpler. That when adrenaline or any of the variant binds here, you have constriction. When it binds here, it will increase what is chrono. Chrono means time. chronotropic. Ino means force or pressure. When adrenaline binds to anywhere on the downside in the heart, it increases the force of contraction. The force of contraction and the rate of contraction. So it is when you go to run or jog, if your body, so swelling outstanding must be heightened for you to be able to cope with exercise. You need to find people that have any form of cardiovascular problem to now understand the benefits of you that you can run or you can walk and you don't faint. Like once you start from a sitting position to a sitting position, your oxygen demand will increase and your heart must be able to cope with all that. So for smooth muscle, we have relaxation of smooth muscles that it relaxes. So if you need when you now bring this back to your normal allergy reaction. Maybe this one that happened in the hospital when you have a patient that is approaching what do we call it now? This serious adverse allergic reaction or defined anaphylaxis. That we know that is anaphylaxis is a form of allergy, right? Allergic reaction, a serious one like that, usually caused by histamine and other ones. So you may want to give antihistamines, but you now understand why you want to give the person adrenaline. Why you give adrenaline? Because adrenaline will cause the blood vessels to constrict. It causes the blood vessels to constrict. When the blood vessels constrict, blood pressure will rise. Blood pressure will rise. Blood pressure will rise. Yeah. The same thing happens to the heart too. That around there too, the blood pressure would rise. This person that is about to probably die, it causes relaxation here. Yes. Hello? Yeah. Samsung. So now let us try to get what happens. This. So now for a person probably in that condition, you see alpha 1 going up, right? You have constriction here because now you want the blood pressure to increase here. The heart to begin to the force of contraction will increase, the rate will also increase. Those two happens there. Now, the point is because adrenaline is also able to cause relaxation of smooth muscles. So, at the level of the bronchi, the person may be able to breathe much more easily than when you don't give that. So, that is at the level. So, the roots will also affect this. So, the reason you also give your adrenaline for these conditions, right? Now, come back to what we are looking at here. So, if you know this is what happens with your agonist. Are this adrenergic receptor. So if I want to produce vasodilation, two things. I will want to block the effect of what? Adrenaline here. To ensure there is vasodilation. If I do that, what I do is the blood pressure should drop. The blood pressure should drop. It doesn't have to be for a long time. Blood pressure should drop. If at this point too, you want to slow down the heart, you will not give adrenaline. Because if you give adrenaline, the heartbeat will not slow down. Do you understand? So you either prevent adrenaline from being released, you can also prevent adrenaline from being able to bind to the receptors in the heart. So what do? In that case, you are introducing an antagonist. So the antagonist may not even be doing anything. And may just be occupying the receptors that adrenaline is supposed to bind to. So adrenaline can no longer raise the pressure. For smooth muscle, we need relaxation. That's what happens here. So the point is, if you now introduce an antagonist here too, what you find is that instead of it producing relaxation, the muscles become much more tensed. That's basic. So the only part of this that will apply to maybe asthma here will be arbitration receptors on the sleep muscle. We want the muscles to be much more relaxed. So that's why we need what? A short acting or a long acting beta 2 agonist. Because the agonist here behaves like adrenaline. Salbutamol as a short acting agent, or your albuterol as a short acting agonist here. So they will behave like adrenaline there, producing more relaxation of the smooth muscles of the bronchioles, right? Now, this is for your adrenergic part. And I said last night, once a drug is short acting, depending on the route of administration and all that, so short acting means that the effect is probably for a few minutes or a few hours, that the onset should be around 3 to 5 minutes. In these conditions, you don't need a drug that will start working in 1 hour's time. You need a drug that wants to work now. So once somebody has a crisis that is asthma, you're looking for a LABA, you're looking for a SABA, short acting, because you want the effect within 2 minutes, 3 minutes, max 5 minutes. So you don't want the drug to last for 1 hour. You just want the drug to probably last for 30 minutes. But the point is, it doesn't last for 30 minutes, so you can always re-administer if there's a need. So for persons that have mild to moderate asthma, for some of them, a SABA is just enough. Short acting, beta 2 agonist, when they have their crisis. So there are conditions in asthma that what you need more than a short acting beta 2 agonist. The person will need drugs, we call it maintenance drugs. They will need preventers. Drugs that will prevent. It's more like they are always on a load, they are always on a maintenance, it's not a loading dose. They are always on a maintenance every day. So for those ones, you probably will be giving them drugs here. These 3 drugs, a drug here, to maintain them in a much more stable condition. Then you now be, that's why you can now be using the LABA or the LAMA. Because you want to say for the next 8 hours, don't have crisis. For the next 12 hours, don't have crisis. So you give them a long-acting bronchodilator, right? Or they will already be on antihistamines or a corticosteroids, which we will get to. That's what you want to prevent. But in a case when there is an emergency, most likely you will give a broncho that's short-acting. And there's some cases that they even add, this person was discussing that they added maybe an antihistamine or this one in the hospital, but that's an hospital setting. Or they can even have some of these, yes, that come in that form. But most usually, for some of them, a short-acting beta 2 adrenergic agonist is enough. So when you talk about the end, what's that? This drug is a short-acting beta 2 adrenergic agonist. It acts on the beta 2 receptors, or the adrenergic receptors, binds with and produces bronchial relaxation, bronchodilation, and that is what you need to say there. So moving on from that, did I miss out on anything because we did this? So I said there are some persons that you could give them a SABA alone, but that's not that they need it, you need to add other drugs to them, maybe an ICS, which we will talk about here. That's what corticosteroid. I stands for inhaled. So for corticosteroids, we mentioned that depending on the routes. Now, for your bronchodilators, there are many routes. You can give it by inhalation. Most of your salbutamol here, you have salbutamol, you can have in the inhaler. Yes. So if the person inhaled it, the route was what? Inhalation. If the drugs that they put in the mouth, right, it still goes through that out. So if the person took the tablet, that was just like a network. I see what we need, but we hope it will be resolved sooner. Now, alright, so I was on bronchodilator and I said that usually you will have so in emergency situation, your choice of route, your route of choice was inhaled, right? And what are you administering there? The salbutamol, right? Your albuterol, because they are short acting. Salbuterol is long acting. Alright? So they are the most widely prescribed bronchodilators, the inhaled beta 2 agonists. For treatment of asthma, they are usually given by inhalation to treat a developing attack or prevent an attack when it seems likely. So the regular use is not encouraged without concomitant use of an ICS. And I mentioned that for corticosteroids, we can have the ICS, we can have these forms.
Yeah.
So for the ICS, what you would get are usually your what? Beclomethasone. That's what you have there. You also have what? You have fluticasone. That form of what? Inhalation. Inhaled form of corticosteroids. Do you understand?
Yes.
So now prednisone, right? Prednisolone. You know what?
There's an I.
So you can oral and then that. So you cannot see an ICS that would have prednisolone. So get the difference there. You won't see an ICS like inhaled corticosteroid as what prednisolone. You have oral and other forms, maybe parenteral forms that way. But for the inhaled form, you're seeing what you will get beclomethasone, butyronate fluticasone. That's what you have there. So I said that some inhalers come with what the mixture of what your ex-SABA and what an ICS. So you have what a bronchodilator and what an anti-inflammatory agent together there. Okay, I'm just going to follow the order of my notes so that I will not miss out on something. So the most widely used are short-acting beta-2 agonists like salbutamol. Half-life of 4 to 6 hours. Produce relaxation of the airways with muscles from what we're talking about here. Half-life 4 to 6 hours. Produce relaxation of smooth muscles, airways smooth muscles, by acting as an agonist. Short-acting beta-2 adrenergic agonist. It acts as an what? Agonist. So I said, once you get this name, you can easily talk about what? The MOA. It shouldn't be so hard, right? As an agonist on the beta-2 receptors of the cells, leading to what? Elevation of signaling molecule called cyclic AMP in moody cells. So the point is, any physiological mechanism that increases cyclic AMP, any physiological mechanism that increases cyclic AMP, most likely will cause relaxation of smooth muscles. Do you understand? So the process is any physiological process that increases cyclic AMP levels causes any physiological process that increases cyclic AMP levels. Once you increase cyclic AMP levels, what you in this case you have what bronchodilation, because we are looking at what muscles in the respiratory tract. If you are to be probably in uterus other ways, what causes uterine muscle relaxation? The point is, increasing cyclic AMP will cause relaxation of what? Smooth muscles. So this one, this SABA, the levels of what? Cyclic AMP to produce what? Bronchodilation. That is the goal. So your SABA or LABA does that by acting like an agonist, binding to what? Beta-2 receptors as an agonist to produce bronchodilation. So by binding to this, it increases cyclic AMP levels and produces bronchodilation. So I think that is gotten. Now we have the LABAs, these are the long-acting ones that you can do that maybe twice a day. We have salmeterol, formoterol, etc. or once daily, once like that. And we have what? IV beta-2 agonists that are sometimes used for severe attacks in hospital settings. We also have oral salbutamol, which is not widely used and have been replaced by LABA. Even we have some, you can find it in syrup for some students too. So you can have it in all the in the parenteral forms and what the enteral forms. Do you understand? So that is for our bronchodilators. Now I'm coming back to our corticosteroids now to draw that. So corticosteroids are serious. So steroids has many good uses and has many side effects. So if you take it for long, it affects your metabolism and others. But the point is, in this case, we need the steroid to suppress the immune system. Why are you giving a steroid? Because we want to suppress the immune system. Why is suppressing the immune system? Because of allergy or allergic reaction is a form of is a type of immune response. we need a corticosteroid because we need to behave as anti-inflammatory. Why would you? Because in asthma we have inflammation. What we want to stop inflammation. So by stopping inflammation, we have to stop what the allergic process. Allergic process is part of what the immune response. So we don't just give an antihistamine because there's a level where antihistamine would not go beyond. We want to give a drug that can stop the immune response to a level. Cytotoxic drugs also affect the immune response, but that's at a higher level. But usually for basic stuff like disability, we give what a corticosteroid. Not because it has any effect they have, but that they can suppress the immunity sufficiently. Are we guys okay? So what we have here, I said that what they reduce inflammation and allergic reactions of asthma by inhibiting the recruitment and activation of inflammatory cells such as eosinophils. We have eosinophils and basophils there. So regular use of inhaled steroids leads to an improvement in airway irritability. What is airway irritability? The ability of that is the sensitivity along the airways. So by giving a steroid, which tends to reduce immune response, you can numb those areas to response to you can numb the response to allergy. So that's the point. So over time, if you give that, you can reduce asthma attack by preventing inflammatory reactions. So it is when you refuse to prevent the inflammatory reactions that you have to now deal with the bronchospasm at the end point. If you can prevent the inflammatory reaction in the first place, it will not get to the point where patients start coughing, starting all of those things because you have suppressed the immune reaction at the beginning. So we have that what the preferred route is still what the inhalational route. So we have drugs that are made into ICS, inhaled corticosteroids. So, but one of the points with suppressing and giving a corticosteroid is that it tends to suppress what we call the HPA axis, among many other things it does. Suppression of the hypothalamic, pituitary, and adrenal axis. Most medications that has corticosteroids has the tendency to produce this. Even your Skinel, your Convatec, you will see it there, they write. So, and they ask you not to always rub it on your face. Just as if it's body cream. It's not body cream. You only apply to the surface you need to apply to. So corticosteroids will suppress this HP axis, hypothalamus, pituitary gland, and then these are hormone endocrine systems. So which will affect the growth and even the proper functioning of the person involved, apart from the other metabolic issues that we get to see along with it. So we have this. So we said it will suppress this. In some cases, it may lead to stunted growth. So aside beclomethasone, budesonide, is budesonide on the board? Budesonide, and we have cyclosporine, we have mometasone. These are examples of what ICSF. So these have a much improved safety profile. Because why is it better? Because when you apply them, the effect is limited to a particular system. It doesn't always access the general circulation. That is why it is better. So the effect is limited to probably the respiratory system, just around there. It's not like it's going around the body. It will not a generalized effect. So that's why it might be safer. Then, now other point here is that what? There's probability of it causing what we call candidiasis, oral candidiasis. Because once you inhale the drug may get at the back of the tongue, the connection between your respiratory part, your nose and nostrils, the mouth. So at the oropharyngeal point, it tends to cause, once the drug is deposited there, what does that? As the drug, a steroid will do what? Will suppress immune response there. So if it suppresses the granule of the normal immunity there, that means some bacteria or fungi can grow and become pathogenic. So people that use this may have that problem. They have what? Oropharyngeal candidiasis. So what is said is that because usually you tend to give the ICS more like a maintenance therapy, but the people are asked to use their drugs before they brush their teeth in the morning. because once you brush, you want to wipe everything in your mouth to an extent, you tend to drink water. So to destroy anything that got stuck at the back of the or once you are done, they are going to put cold water in your mouth, what we call Swiss swash, just the way you can gargle or open and then just you spit out or you swallow. So the point is that that helps to reduce the development of this form of candidiasis that comes from what? Because so the point is, once you start a medication like prednisolone, you want to suppress, I told you what, inflammation is part of the immune response. The drug will not separate inflammation from other immune response. So in suppressing inflammation, it also suppresses your natural immunological response. So you can get the cure you need and also suffer from depressed immunity, like not to the level of an HIV patient. What is AIDS itself? Immune deficiency. So you can be on steroids and you have acquired, not AIDS now, you have acquired what? Immunodeficiency. All of the drug. So these are some of the problems we have with steroids. Right? Okay. Having said that, so this eventually disappears if the drug is stopped or reduced or can be managed by raising the amounts after inhalation. So ICS improve lung function and also which will lead to improvement in asthma control. So we now have infused dose combinations inhalers combining a LABA and an ICS. So if you see a drug that contains a LABA and ICS, you already know that drug is not for emergency situation, it's for maintenance. Because LABA takes a long time. ICS itself is a preventer. LABA, although is a reliever, giving a long acting, the drug tends to work over a long period of time. So a person can ask asthma now, serious one, I want to give LABA plus ICS. You will give it to a patient as well. After you're giving a drug for the acute attack, you give it to them the chronic issues that come up with them. Have you this clear? So the other drug class is what we call the leukotriene receptor antagonist, like your Silucas. So the name, you know, the leukotriene receptor antagonist. So the drug Montelukast would antagonize what? Leukotriene at the receptor point to prevent leukotriene binding receptor to initiate some of these inflammatory activities. So we have Montelukast that given as a once daily dosing, but it's not one of the drugs. Now the other drug is methyxanthines, right? Earlier I mentioned methyxanthines. Methyxanthines. Methyxanthines, yeah. We talked about our aminophylines. Aminophylines. Yeah, and sulfines. So, in natural sources, we talk of tea, right? Cocoa products like caffeine, maybe chocolate, and essence. Like, those are natural sources. Where you tend to get probably that's all this bromine, right? So what we have there, we have aminophylines, which are also bronchodilators.
Nobody's joining again. Maybe if you send the link.
Another link. Do we need to? Is it the same thing or another link?
The same link will go. The same link will work. Maybe they don't know that it's back or something.
We have gone far. Sorry. But is it the same link? What did you what was going to say? Are you sure it's the same link?
It's work. It's just 2-3 people that are joining.
Let me put up my back. Because the lady that chatted was from the class.
It was getting to 20 before, now it's just 2 and 3.
Can you see name of friends, eh?
No, you won't see. These are people from. Good afternoon, sir. Well done, sir. Please, can you save up the video, sir?
Hello, now. What? Are you okay? Are you normal? the whole system has gone haywire, they don't produce the maximum effect. So the best effect will be at the start of or to prevent all of what you're seeing. So we have the biologics. I mentioned your monoclonal antibodies. We have your xylitine. I mentioned your montelukast. You have zafilukast. You have your xylitine. These tend to modulate the immune system. Modulate component of the immune system that are also responsible for inflammation. That's all they do. So they are also what anti-inflammatory, basically. Okay. Moving on to what we talk for asthma, to a large extent, applies to COPD. Because we usually go through this drugs. Lama, and ICS, the same order, just the same order. So I will. So and in the notes too, I talk about the delivery systems now. For the inhalers that I use, the different type of inhalers, we have what we call a pressurized metered dose. Metered dose there, meaning that itself is already measured that every time you take a puff, there is a quantity of drug that will be delivered. So you're not trying to measure the drug. When you take a puff, so it is. We have the DPI2, we have nebulizers, we have the listen for children, we have breath inhalers like them. We also have what we call the dry powder inhaler. So we have brain type. So those ones they affect what you say. Now to come to cough. Now talking about cough and these ones, we are looking at what conditions of the upper respiratory because cough is there. Although cough is a symptom in asthma and COPD, but cough is actually a symptom in the upper respiratory tract. So with the cough, we have what called a cough reflex. We have a cough reflex, we have a stimuli, how it runs from the periphery to the central areas and backward to produce other. But that is not really our focus. Our focus will look at the drugs that you need to manage. So if someone is coughing, you give the person an antitussive agent. You give them an antitussive agent. Right? So here, I mentioned what an expectorant. Now, why did I highlight them? Because you need to understand, when you buy a cough syrup, you need to understand what you are buying. So, generally, it's not just the cough, you have other things there. So here, we have what called the expectorant or mucolytic agent. What does it do? They loosen the sputum and it helps you to flush them out. So mucolytic is lysis, mucus lysine. A mucolytic agent with lyse mucus. Expectorant helps you to expel them, right? So your mucolytic agent, you have things like your head, your food, there too, or it's cleaner to the respiratory part. One of the symptoms accompanying common cold is excessive nasal secretions. So that is more or less what is with your rhinitis, watery eye, runny nose. Watery eye, runny nose. Now, in this case, for people that have that, basically the drug they need is what we call a drug like a drug that acts on the alpha-1, that acts on the blood vessels. So when there is cold, that is how your blood vessels behave. When there is cold, your blood vessels tend to constrict along the extremities. Because when there is cold, the ambient temperature is probably lower than your body temperature. If your blood vessels at the extremities relaxes, they dilate more, you lose more heat, more energy. Your body will have to work more. So the reason why some people end up shivering. Your shivering is not just because you are catching blood. Your shivering is your body trying to generate heat to maintain your internal homeostasis. So that's so then when you are cold, your blood vessels shrink and you tend to feel numb because your body is trying to reduce the flow of blood towards the extremities when you can lose heat. You understand? So that is that. So when there is a lot of heat, you tend to sweat a lot because now your body must now lose the heat that is already pent up inwardly. So you now tend to have a work up vasodilation at the extremities everywhere so that your body can push out more heat. So when persons have rhinitis or so, they have watery eye, runny nose, and all of that. Usually, to stop it, you need a drug that can constrict the blood vessels toward that area, around that area. Do you understand? You don't want the blood vessels to just loosen or just expand more, to lose more water, more fluid, all of that. you want to tighten up. Is that okay? That is why alpha 1 agents are really important here. So what we have, so I think I just read a part of this note to explain. I said one of the symptoms accompanying common cold is excessive nasal secretions, and many OTC remedies for cough also contain a vasoconstrictor. You know that many drugs we give for cough, because most patients have cough. They can have cough, rhinitis, and everything together. So if you don't want if you want a cough medicine that does not have this, you have to check it and tell them I don't want this. This is what I want. But usually some drugs are just make sure that it's like Bogonishe. It is antitussive. It is also for other issues of the upper respiratory tract. Right? So most cough medicine will call a vasoconstrictor to reduce what nasal blood flow and thus reduce secretion. The point is, you want, that I say hot and cold environment, you want to reduce blood flow to those areas to reduce the loss of heat and all that. So, the vasoconstrictors commonly given is, I think, is phenylephrine, which is an alpha 1 agonist. You see, if you like this, you don't need to cry what I said. That what? Adrenaline on alpha 1 is what? Will cause vasoconstriction. Phenylephrine that you give is an agonist at that receptor site. So it produces vasoconstriction. Because you want to prevent excessive blood flow to those regions where water and fluids tend to leave easily. So you're giving what? Phenylephrine there, which is an alpha 1 agonist, that now mimics the action of what adrenaline. So sometimes you see them as what sympathomimetics. It mimics the action of adrenaline. So you cannot just inject adrenaline into your nostrils. Now, vasoconstrictors like phenylephrine must not be given to patients taking monoamine oxidase inhibitors, since this may greatly enhance the activities of the pathomimetic agent. I don't know, I have to explain that to you since it's residing in your notes. What are what are the agents I mentioned here? Monoamine oxidase inhibitors. Now, maybe you might hear this later. You might be unlucky not to hear it again until your counsel. What are we like? Monoamine oxidase. As long as you see the word ASC at the end of anything, that is an enzyme. Right? Monoamine oxidase generally are enzymes that would help recycle or break down circulating catecholamines. Monoamine oxidase, monoamines. So they are oxidase enzymes that would tend to help you recycle or they tend to remove from circulation circulating monoamines. Things like your adrenaline, dopamine, noradrenaline. Okay. So the enzymes that help to break them down. How do I explain it? Your body releases adrenaline, for example. So as long as you have that adrenaline circulating, it exerts a physiological response. So something must stop its activity. Something must stop its activity. Do you understand? So one of those things are something like your monoamine oxidase inhibitors. So monoamine oxidase, which is an enzyme that helps to remove them from circulation. So it's when they are removed that their effects will no longer be seen. Do you understand?
We didn't get you said monoamine, there are enzymes that help to circulate.
Monoamine oxidase. Enzyme systems that would help to reduce the levels of circulating monoamines or catecholamines. What is catecholamines?
These
catecholamines, monoamines, amines, adrenaline, dopamine, noradrenaline acts like that. So once your body releases them into the system, right? They are going to exert a particular effect or effects. So long as they are there circulating, nothing can stop the activity. So we need enzyme systems or other things that can. It's like when you collect waste back, like you have your all this lamata, waste management. They come, they pack your trash, and they take it away. So once you have the trash there, the whole place is dirty and smelly. Somebody must come to, it's like to clear them off, bring them down. So we have for acetylcholine too. You've heard of acetylcholine. There's time I mentioned acetylcholinesterase. I've mentioned in class. Acetylcholinesterase is enzyme that will break down what acetylcholine. It will cover it from what circulation. Then that's what acetyl-CoA. Acetyl-CoA and other ones. Yes, and so for acetylcholine, we have what? Acetylcholinesterase is called. For monoamines, we need what? MOAIs. So for monoamines now, we need what? Mono. I need the green pen to do that. So for something like adrenaline now, or not adrenaline, we need MAO, monoamine oxidase, to break it down. Do you understand it? So when you bring down the level of adrenaline, the level of adrenaline circulating body will drop. What happens to your blood pressure? Normalize. Do you understand it? So, what are MAOIs? Monoamine oxidase inhibitors. So this drug will inhibit the action of what? Monoamine oxidase. This is out of our topic of discourse, but you might just get it. Adrenaline and other adrenaline dopamine are circulating as what monoamines. They exert a particular effect. We need something to clear them off. Right? When you clear them off, the physical effect will also disappear. Now, by using a monoamine oxidase inhibitors, that drug will prevent monoamine oxidase from actively removing this one from the circulation. What happens now? Their effect will persist. So imagine you now have this, you have the levels of circulating monoamines very, very high in the body. You will see the attendant effects. The pressure will be high and other issues there. So we now said, what led us to this was it? We were talking about, I read about, what did I read about? I came to the name of it. I was talking about vasoconstrictors. Because vasoconstrictors themselves would, so vasoconstrictors affect your blood vessels and produce what? Vasoconstriction. Increases the blood pressure. So a person, you have a drug doing this, phenylephrine or pseudoephedrine is doing this. The person now took this drug, meaning that what? You have more of this in the body. So you produce more of this effect, but not only in the respiratory system, but when you check this body blood pressure, it will be very, very high. Yeah. So the point is, which kind of people do you give MOAIs? That's the question you want to ask me. People that are depressed use MAOIs because it is physiologically we see that depression is a state when if your adrenaline is just like when adrenaline pumping, you can't be depressed and adrenaline is pumping. You get the logic? People that are depressed, they are in a form. Is it sombra and all that? So the point is to boost or increase the levels of some of these monoamines that tend to make them more active physically and also mentally. Do you understand? So the MOAI are for people that are probably have issues with depression. So the point is, the drug is keeping the levels up. You now add another drug that also will constrict the blood vessel. So what you get is not only what happens here in the nostrils, right? It also affects other systems in the body. So this is just you asking if a person has to take that drug. At times, if it's an elderly person, because I do not expect a young person to be on MOI, an elderly person taking it, you now have to be careful giving another constitutional drug, or even giving adrenaline, or giving drugs that are what sympathomimetic. Do you understand? So that was why that point was mentioned there. Please, because of our time, probably you asked me that in person. So now, having talked about your vasoconstrictors like what phenylephrine, pseudoephedrine, they are what? They are agonists at what? Alpha 1 receptor. They constrict the blood vessels along the nasal passage. So ensure what? Loss of fluid and water is what? Reduced. So what kind of like the draining that comes with the eye and the nose would naturally reduce with the drug. So now, for people that have rhinitis, we give them the same drug. But the point is, we have two types of rhinitis. We have the allergic rhinitis.
Viral rhinitis.
But that one. But another rhinitis you should know. There is a medication-induced rhinitis. There is a medication-induced rhinitis. We call it rhinitis medicamentosa. Rhinitis medicamentosa. So what happens? The person has rhinitis. You give the person what is medicament? Rhinitis
Medicamentosa.
rhinitis medical. So the point is, you give the person a drug to treat rhinitis. So within 2 or 3 days, rhinitis is cleared off. Because you overdose the drug, you gave you that drug, after like 3-4 days or about 1 week, the person will rebound rhinitis, not because of the allergy or viral infection, now because of the drug you gave. So because of drug-induced rhinitis. Do you understand it? So that's what alpha 1 agents like phenylephrine, pseudoephedrine, drug-induced rhinitis. Now, I said for other autisms that can be given what antihistamines, usually the other sedating ones like your pyridine, chlorpheniramine are given. I usually want to give you that time because the drug will produce was sedation alongside blocking the allergic parts of the rhinitis. So you want to give them today. That one's said too. So for many of the for cough suppressing drugs that are given, you tend to give opioid drugs. You tend to give opioid drugs, which may include morphine, heroin, and codeine. And they should be used with caution because of tolerance and addiction. So you will not find a cough syrup that contains morphine or opium or tramadol. Have you seen? You won't. What you will find, Jessica, you find those that come with codeine because codeine is still lighter compared to morphine in form of addiction and that was pain. Because cough will come with pain. Cough will come with pain. Your opioids as an analgesic tend to suppress cerebral activity, your mental activity. So you are giving the drug to block pain centrally and peripherally, to an essence sedate central activity that helps you to feel the pain, to also ensure that that person can sleep well. It may also depress the respiratory system to an extent that the person can sleep. Or else, the person may not be able to sleep at night because of the cough, the coughing and the rhinitis. So now, usually apart from the codeine, you may find what we call dextromethorphan. Dextromethorphan is given. We have to have dextromethorphan. Dextromethorphan. Why is this drug important at times? And this we get today. Why? Because we call it a synthetic narcotic analgesic, and it's as potent as codeine. So some of these medications may contain codeine, some may contain this dextromethorphan. It's a synthetic form, a synthetic analgesic that is as potent as what codeine, but it is slightly more active than it can cause constipation like codeine, depending on the dosage and frequency of use. So now that some may contain what called codeine, similar to codeine 2. It presses the cough center. It seems slightly more active than the codeine. Lasts for about 4 to 6 hours with similar effect. So codeine, so you might see constipation and all of that. We have dosapram too. It's most effective, stimulates respiratory stimulant and is given by internal infusion. Those are adjusted. But that will be for anticipating that you can give codeine, you give your dextromethorphan, your full codeine. Those are become as what analgesics to help with the cough. So they prevent cough. In a way, they tend to suppress the respiratory system. To an extent, they also tend to suppress to an extent this central nervous activity. You notice. So these are what you find with your just discussing lower and upper respiratory tracts. I want to end up in 5 minutes. So that's that. So with that, I finished the part of the note I gave you. So I'm trying to look into another note to see the things I missed out. So we're talking about what H1 blockers. Why we need what H1 blockers? Histamine H1 blockers here, antihistamines, right? For upper respiratory infections and problems there. We need decongestants. Your decongestants are your alpha 1 agonists here. Nasal decongestant. You want to decongest the nostril. So your alpha 1 decongestant, which are what symptomatic amines. You need your antitussive agent for cough, especially also for cough. So, having said that, what is mentioned about the half-life and all that, which I think I can say this with. Diphenhydramine is mentioned here. So this is what, and that's what histamine H1, right? To produce sedation there. Diphenhydramine. That is just, this part is just really about the dose, more details of the dosages, the half-life. Second generation antihistamines, done. Nasal and systemic decongestant. I mentioned your phenylephrine. Okay, let me see. I said frequent use of decongestants can result in intolerance and rebound nasal congestion. That's what I explained there. That you see some person, they're always using this thing that they put in your nose. They're always having catarrh, cold, and flu. They always have, because you give the drug, it clears for some days, not because of this, you have rebound. They keep on having rebound. So the point is, you just need to stop them from using the drug for a long time. Because so long as they are using the drug, they keep on having a rebound effect. So the conditions are remember as nasal spray, all that. We have systemic decongestants too. Side effects, they can make the client jittery, nervous, restless, and will diminish, which diminishes with time. That was said, hypothyroidism, diabetes mellitus. Drug interactions, I mentioned beta, okay. Although I didn't mention beta blockers here, I mentioned MOIs, I mentioned caffeine briefly. International glucocorticoids, we've done that. What are the others? Dexamethasone, we have beclometasone, we have budesonide, we have fluticasone, triamcinolone, we have but once you know two, you are good. Antitussive agent, we have a dextromethorphan, a non-narcotic, is a non-narcotic agent. So why is it? So the reason why it's better because as a non-narcotic, it will not produce the level of what addiction. And then you see what things like codeine. Although most of what you find is codeine, but using dextromethorphan is a non-narcotic agent, it won't get to that point. You have expectorants that are losing up bronchial secretions, etc. So they can eliminate them by cough, e.g. guanfacine. So expectorants here, you have guanfacine, as I read in your note. Drugs for lower respiratory, which is majorly your asthma and COPD. Formidable causes, talk about that. Alpha and beta adrenergic agonists, talk about that. The beta 1, beta 2. So, okay, Ventolin, that's albuterol, you have that. Isoproterenol, I mentioned tropulin as an example of your methyxanthines, 10 to 20 microgram per mil. What else? I think that's it. So I think that results it for that part. If you revise that, So the only part I didn't get to discuss today is just where I should talk about tuberculosis. Tuberculosis, and I believe I've done that maybe somewhere before now. So probably maybe next class I get to talk about anti-tubercular drugs, the first line and second line, which is just rights, right? So we should stop there for today. So, thank you for listening. And see you when I have a question.
Yes.
Huh?
The question.
No, there's no stop that.